Good day. I am Brian Hoffland, President of Research to Prevent Blindness. Welcome to RPB's Lunch and Learn Eye on Diabetic Retinopathy, or DR. Research to Prevent Blindness is a leading nonprofit organization supporting eye research directed at the prevention, treatment, or eradication of all diseases that damage and destroy sight. RPB was founded in 1960, and over our 60-year history, we have awarded more than $383 million in research grants to the most talented vision scientists at the nation's leading medical schools. As a result, RPB has been associated with nearly every major breakthrough in the understanding and treatment of vision loss. In today's educational session, our third Lunch and Learn event, you will hear from two RPB-supported talented scientists about diabetic retinopathy, or DR, pathology, disease management, and new research directions. One of our speakers, Dr. Jesse Shallak, received an RPB Career Development Award, which helps promising vision scientists launch independent research careers. The other speaker, Dr. Jennifer Sun, received an RPB Physician Scientist Award, which supports critical research by clinician scientists who play an important role in bringing their knowledge as physicians into the world of research. Thanks to all the generous supporters of RPB who make our work possible. The importance of supporting medical research has never been so apparent as today. We thank you for your partnership in supporting innovative vision research to ensure that new breakthroughs are possible. If you have not yet supported RPB, please consider doing so to help make sure that we are able to continue to support these breakthroughs. But getting back to today's session, let me introduce our moderator. Sanjay Duda, PhD, is currently Vice President of Research at JDRF, where he has worked since 2009. He oversees JDRF's efforts to cure type 1 diabetes and improve the lives of those living with it. His work covers beta cell therapies, immunotherapies, and glucose control and complications. He also is responsible for international partnerships with government, non-government, foundations, and commercial organizations. He previously worked as Associate Director of Translational Clinical Biomarkers at Bristol Myers Squibb. Before that, Dr. Duda was Principal Scientist of Cardiovascular and Metabolic Diseases at Hoffmann-La Roche. You could say that he has come full circle in his research career, as he was a JDRF postdoctoral fellow in the Department of Cell Biology and the Joslin Diabetes Center at Harvard Medical School. Dr. Duda will introduce our two speakers for today and moderate the Q&A session at the end. Each speaker will speak for 20 minutes and I will serve as timekeeper. I will give each a warning at the 18-minute mark. We want to make sure that we have ample time at the end for a robust Q&A. Dr. Duda, take it away.
Thank you, Brian, RPB, for inviting me. I have been super excited following this field for a number of years and actually never attended an RPB meeting. My colleagues have. So it's a privilege for the first meeting here to moderate this session here. And what we're going to do right now is do a little bit of reverse engineering. We'll go through clinical therapies, trials, stratification. I'm already introducing Dr. Jennifer Sun to you, who is an associate professor of ophthalmology at the Harvard Medical School, and her lab is at the Joslin Diabetes Center. Amongst numerous honors, achievements, publications, some of the key ones is she's currently chair of the Diabetes Retinopathy Clinical Research Network, a National Eye Institute effort and an initiative there, which oversees multiple clinical trials, imaging, and other things here. Speak about anti-VEGF, plasma kallikrein inhibitors, biomarker for stratification, prognosis, diagnosis. Jenny has done it all, and it's my privilege. I've been working with her on many projects here, and most recently on the JDRF and Mary Tyler Moore and S. Robert Levine Foundation's Diabetic Retinopathy Moonshot Initiative, which she co-chairs with another investigator. So it's my privilege to introduce Jenny and look forward to her presentation, a friend as well as an educator to me. Jenny, please take it away.
Thank you so much, Sanjay, for that very generous introduction. It's really a pleasure to be here today, and I have to thank Brian and Diana for the invitation to speak. So I'll be talking about evolving paradigms in diabetic eye disease, and here are my financial disclosures. I'll just start. My field is diabetic retinopathy, and I'm highly motivated in part because we know that diabetes is an enormous growing global epidemic. Here are the projections and estimations of the numbers of adults with diabetes in millions from the International Diabetes Federation from their first 9 atlases up through 2019. And you'll see that from 2019 to 2045, it's projected that we will go from having 463 million adults with diabetes worldwide to 700 million. So this is an enormous increase. And with that increase in diabetes, there are increasing numbers of patients at risk for vision loss from diabetic retinopathy. So in the US, it's been projected by the CDC that the estimated number of Americans with retinopathy will double from 2010 to 2050 to 14.6 million. As part of this, of course, there's a burden of visual impairment that evolves with it. And when we look at the healthcare dollars that are spent on diabetes-related blindness, this estimate is back from a few years, from about 2010, 2011, the nation was spending about 500 million annually. And this doesn't account the real person cost of blindness and visual impairment from diabetic eye disease. So what do we know about diabetic retinopathy? Well, it's the severity spectrum. And the early treatment diabetic retinopathy study developed a scale for looking at diabetic eye disease that goes from no disease to mild, moderate, severe, non-proliferative retinopathy, all the way to the most advanced form of the disease, proliferative retinopathy, where we see new blood vessels that are abnormal growing in the retina. And at any one of these stages, patients can also develop thickening of the central retina or diabetic macular edema. Diabetic macular edema, or again, this swelling of the central visually important retina, results from leakiness of blood vessels due to damage from the high blood sugars. And it's actually the most common cause of vision loss in our diabetic patients in the US today. And here at the bottom, you see a cross-sectional thickness of the retina on this OCT image. You see on the top a normal OCT image with a normal little dip in the middle. And on the bottom, you see a picture of an eye with diabetic macular edema, or DME, with large fluid-filled spaces and an elevation of swelling. And as you can imagine, when this swelling occurs, the cells don't work as well, and it's easy for the vision to be lost. The other major cause of vision loss in patients with diabetic eye disease is PDR, or proliferative diabetic retinopathy. Again, this is an eye here where you can see a picture of a large frond of vessels growing from the optic nerve. These are abnormal. And this can lead to bleeding in the eye. In fact, you see several areas where there are red preretinal hemorrhages here. Or over time, as the tissue contracts, it can lead to scarring and traction detachments of the retina. Again, a high risk for severe irreversible vision loss. So just to set the context, I'll say that before 2002, we really only had one major way to treat all diabetic eye disease, and this was laser photocoagulation. I have here a photograph of 2 of the pioneers of laser surgery in the eyes of patients with diabetes. And laser photocoagulation was found to be very effective for both treating DME and PDR. And yet it came with real costs. Here's a picture of an eye of a patient who's undergone panretinal photocoagulation for PDR, and you can see the widespread scarring. We basically put thermal heat burns into the retina, and as you can imagine, this does have some real implications for reducing peripheral vision in the eyes of patients that have this treatment. So although it's effective at reducing the abnormal vessels, it does create destruction. And in 2002, the Diabetic Retinopathy Clinical Research Network was formed, now known as the DRCR Retina Network. The DRCR Retina Network is an NIH-sponsored collaborative network of clinical sites across North America, dedicated to scientifically rigorous, impactful clinical research of retinal diseases. As Sanjay mentioned, I have the honor of serving as the chair for the diabetic retinopathy initiatives for this network. And in our first 15 years, we concentrated solely on diabetic retinopathy because it was such an issue and because we really did not have major treatments other than laser therapy. And so in the 28 trials that have been completed to date through the DRCR Retina Network, we actually have been able to really change the care for the eyes of patients with diabetes in a substantial way. I'm not going to spend a lot of time on this slide just because this is a listing of some of our major trials that have led to changes in management of diabetic retinopathy, but I will go through just a quick summary of how we approach treatment of eyes with diabetic retinopathy in today's paradigms. And as part of that, I just want to show you this data from one of the first trials that the network did, our protocol I. We number our trials by the letters of the alphabet, in which we compared laser treatment, which was the gold standard at the time. And you can see the purple curve represents the eyes of patients that were treated with laser treatment for diabetic macular edema. And over the first year, at the 1-year time point, these eyes gained on average about 3 letters of vision. In contrast, as you can see, the blue and the orange curves were eyes that were treated with injections of anti-VEGF medication called ranibizumab or Lucentis. And you can see at that 1-year time point that there was a very strong superior outcome in the eyes treated with anti-VEGF therapy. Instead of 3 letters, they gained on average 8 or 9 letters. This was a massive change from what we had known in terms of treatment outcomes. And it really started a sea change in our landscape of care for diabetic retinopathy. And so the anti-VEGF treatments have become a large mainstay of treatment for both DME and for proliferative diabetic retinopathy. So on the top, you see 2 panels of an eye that started before anti-VEGF with some diabetic macular edema. This is a color map where the red and the white represent areas of abnormal thickening. And you can see after anti-VEGF, about a month afterwards, this eye normalized in retinal thickness and actually had a very normal looking color map. In the bottom 2 panels, you see an eye with proliferative diabetic retinopathy. This is actually the eye I showed you before in the slide. And 1 month after treatment with anti-VEGF medication, many of these abnormal vessels look like they've almost melted away. There is still some residual preretinal hemorrhage, but that will tend to disappear over time as well. So anti-VEGF therapy is highly effective for both DME and for PDR. And we've also seen that injections of these medications can improve the severity, can improve the look of the eye. This is an eye that got 3 years really of continuous monthly treatments with anti-VEGF and improved at baseline from a high-risk proliferative diabetic retinopathy status all the way at month 36 in the photo on the right to mild non-proliferative disease. It's still an open question, and this is something that the DRCR Retina Network is collaborating with JDRF on a study that should be reported out shortly, looking to see if preventive therapy is helpful in terms of treating eyes with severe non-proliferative disease in preventing proliferative retinopathy and diabetic macular edema. So what is the current care for diabetic macular edema? Well, we know that anti-VEGF therapy is first-line therapy for most eyes with center-involved DME. So if you have friends or relatives that have DME, they're very likely getting anti-VEGF injections. But it depends to some extent on what the vision is of the patient at baseline. So here's where studies from the DRCR Retina Network have really helped us differentiate out which groups of patients need to be treated immediately and where can we hold. When a patient has good vision, 20/25 or better, despite having center-involved diabetic macular edema, we found that actually we can just hold therapy and treat only if vision worsens during follow-up. And the visual outcomes long-term are very similar as to if we started anti-VEGF right away. When a patient has some visual impairment, so they start to have mild impairment from 2032 to 2040, we do start treatment, but we've done a comparative effectiveness study looking at the 3 major commercially available anti-VEGF agents, Eylea, Lucentis, and Avastin, and they're all very similar for vision outcomes. In contrast, patients who start with vision impairment to 20/50 or worse, we definitely see that aflibercept, also known as Eylea, is superior to some of the other agents, in particular Avastin or bevacizumab. So this has helped us direct our therapies for these patients. And we've also done studies looking at steroids and the role of macular laser, which do have a role for selected eyes. In terms of proliferative diabetic retinopathy, we've compared anti-VEGF and laser treatments, found them both to be safe and highly effective alternatives for PDR. So the treatment decision is based very much on the individual characteristics of the patient, their ability to come in for monthly, potentially monthly visits, and comply with therapy. We've also looked at surgery, and a trial that we published out at the end of last year suggested that vitrectomy surgery and anti-VEGF therapy are also both good alternatives for eyes that have bleeding or vitreous hemorrhage from proliferative disease. So where does a field go from here? Well, we have successful treatment of late-stage disease, and this sets the bar high for future novel therapies. But we do have major unmet needs for diabetic retinopathy that remain. There's no question research from groups like those sponsored by RPB and by JDRF are highly needed to develop more effective treatments for advanced complications and vision loss, to develop preventive therapies that slow or reverse the course of disease. And in particular, we need a more complete understanding of how disease progresses, both in the natural history and in response to treatment. So I'm going to talk in the second half of this session about what we're doing in terms of looking at changes in the diabetic eye in more granular and more detailed ways than we ever have before. This diabetic retinopathy severity scale that I showed you is based on photos that are taken of small portions of the retina. And you can see that what we've done here is montaged these small fields into larger areas to evaluate larger sections of the retina at one time. Well, this is because back in 1967, when the Ehrlich-House Symposium developed the early form of the scale, the camera technology was not good enough to take larger retinal fields. And yet we can do this today. In a quarter of a second, we can take a field that encompasses about 82% of the retina. And with this ability to take these ultra-wide fields, what we've seen is that there's a lot of pathology outside the standard ETDRS7 fields that we've typically used to characterize eyes of patients with diabetes. And in fact, that peripheral lesions are present in up to 50% of eyes and are more predominant in 50% of eyes. They're reported to suggest an increased severity of retinopathy in about 10% of eyes. And the presence of predominantly peripheral lesions may actually increase the risk of retinopathy worsening and progression to PDR by 3 to 5-fold. This is something that's under investigation now in a current ongoing DR-Sierra Retina Network study that should again report out later this year. We have other advanced imaging modalities, and Dr. Shallick's going to talk about adaptive optics, which provides incredibly high resolution images, but even other imaging modalities such as fluorescein angiography, where we inject dye into a vein, take pictures of it as it goes through the retinal vessels. This is a standard technique we've relied on for decades, but as you can see, as you get to the central look at the microvasculature, there's a lot of blur in here, and the resolution is really not adequate to resolve. In contrast, some of our newer modalities, such as optical coherence tomography angiography, are non-invasive, easily used modalities that can give us that very high resolution look at the smallest blood vessels. So OCTA, as I said, is a non-invasive modality. Blood cell movement is represented by a bright signal, while static tissue, the retina around it, remains black. And it can give us a look not just at the small vessels, but it lets us look through the layers of the retina to non-invasively segment the central retinal plexuses into superficial, intermediate, and deep layers. And you can see here from the schematic how those layers interact, where we go from the top layer of the retina where the superficial capillary plexus is present, through the middle or intermediate capillary plexus and down towards the deep capillary plexus, which in the past has not been visible by our standard imaging methods. So multiple studies have now shown that with increasing retinopathy severity, you start to lose vessels in the central retina. And here are examples of eyes progressing from less severe, no DR, all the way through to PDR. You can easily see that there are darker areas that represent areas of non-perfusion or blood vessel loss. At Joslin, we've looked at these studies across hundreds of patients and certainly documented that vessel density decreases with worsening retinopathy in all 3 plexuses. But the thing that's really interesting in an article we published last year is that not only does vessel density decrease with worsening retinopathy, but there are differences in where that vessel density decreases the most in eyes with early stage versus later stage disease. So this is a plot looking at all 3 vascular plexuses, superficial, intermediate, and deep, looking at eyes with early stage disease, comparing those with no retinopathy to mild non-proliferative disease. And you may be able to see the main difference is really found in the deep capillary plexus. In contrast, when we look at eyes with later stage disease, in this forest plot here, the major differences are really shown in the superficial capillary plexus. So this tells us that as we explore increasingly severe retinopathy, we may need to change our focus as to which vascular plexus we're looking at and how we're identifying differences. I'll also say that not only are we looking at the microvasculature, but there's an increasing recognition that a great deal of diabetic pathology is neural in nature. Our group has been particularly interested in looking at disorganization of the retinal inner layers. And we identify this by saying that in normal eyes, in these cross-sectional scans of the neural retina, we can typically very nicely segment out the inner retinal layer boundaries. In eyes that have drill, we are unable to segment those inner retinal boundaries, and we find that frequently eyes with drill have worse vision. Not only do they have worse vision at the time of the scan, but they're more likely to have worse vision down the road. This is some data from a study we did where we looked at early change in drill over 4 months, and we found that it was strongly associated with future visual change at 12 months. And what we found is that on average, within the very central retina, within the 1 millimeter zone, a 300 micron increase in drill over 4 months was predictive of worsening of one line of vision at 12 months. So this is the start of really looking to see, can we predict visual outcomes in the eyes of patients of diabetes, which to date we have not been able to do. Drill is not only associated with visual acuity, it's also associated with very fine microperimetry changes. These are changes in the central visual field within the center of the visual field. And we found that in a study where eyes were being treated for DME with anti-VEGF injections, changes in central microperimetry or visual field were predicted by early changes in drill, both at 12 weeks and at 24 weeks. And interestingly, this wasn't associated with changes in the overall retinal thickness. So this is a host of information that is not captured by our current ETDRS-DR severity scale, which only looks at the central retina, only looks at vascular lesions, and yet, as I've mentioned, there are many lesions in the retinal periphery, in the deeper vascular layers of the retina, and in the neural retina that are very important for how people with diabetes can see. An ongoing effort is really the ideal visualization of how there's an interplay of neural and vascular and visual function in the eyes of patients with diabetes. And so rather than just a continuous scale looking at the vascular disease, some of us over the last year or two have really gotten together to envision a more multidimensional, holistic approach to staging of diabetic retinopathy. And not only do we need to look at what's going on inside the eye, but it's going to be very important for us to put this in the context of systemic health, the blood sugar control.
You're at the 18-minute mark. You should wrap up.
Hypertension and cholesterol. And this is a figure that was published in Ophthalmology in an editorial that Sanjay and I co-authored at the end of last year, and is part indeed of a larger effort that's being sponsored by JDRF, also by the Mary Tyler Moore and S. Robert Levine Charitable Foundation, where we're looking to understand how can we re-envision the diabetic retinopathy disease staging system so that we can more accurately and reliably predict future outcomes. We've started this by forming 6 working groups in the areas of vascular retina, neural retina, systemic health, basic and cellular mechanisms, visual function and quality of life. And these groups, as we speak, are busy combing through the literature to understand what other things other than vascular retinal characteristics might be included in this retinopathy staging system. So I actually will end there just a little bit early. I know this was a super speed through talk of both the current care paradigms for diabetic retinopathy and where we're really headed in the future as we pull in all of this truly amazing information that we're getting about the pathology and the pathogenesis of diabetic retinopathy from these various advanced retinal imaging modalities. I'll just end by thanking, clearly this is the work of many collaborators, research assistants, clinical fellows, study coordinators, and of course supported by wonderful foundations and institutions, including Research to Prevent Blindness. So thank you very much.
Thank you so much, Jenny. What an informative presentation. And also what I found to be very hopeful for the future. And that's really, really great presentation, Jenny. We'll come back to questions at the end here. But I want to switch to our final speaker here, Dr. Jesse Shalik, and he is an assistant professor of ophthalmology at the University of Rochester. He has a background in biochemistry and neuroscience, but what he's going to talk about today is mostly what he developed during his postdoctoral training in adaptive optics technology. Now, you heard about so many therapies, staging of the disease, how we have advanced our knowledge from Dr. Sun. Jesse, Dr. Shalik, is going to take us many layers deeper into live imaging of individual cells, retinal cells, to study their vascular flow. As you know, it's both a neuronal and a vascular disease, but this has tremendous applicability in translational research. I believe this can be not only useful for diagnostic and prognostic purposes, but eventually can also lead to better therapies here. And what he also will provide insights into is how this can also help in whole body systemic health. So it's perfect segue from Jenny's last slide. So I invite Dr. Shalik to take it away from here. Jesse?
Great. Thank you, Dr. Duda, and thank you for organizing to the Research Prevent Blindness for this opportunity to speak to you today. So I'm calling in today from sunny Rochester, New York, where I'm assistant professor in the Department of Ophthalmology at the University of Rochester. And building on Dr. Sun's fantastic overview of diabetic eye disease and what is known about the current state of the art of imaging and treatment, what I hope to do in this presentation is to give you a glimpse of the future. I think anyone suffering from disease needs a glimmer of hope of where things are going. And what I'd like to share with you today are some exciting advances that we're building in ophthalmoscopy, that is imaging the back of the eye, that may shed light on the earliest stages of diabetic eye disease. So let's begin with this typical image that a clinician would see of the back of the eye. And I like showing this image first because it reminds us that the tissue that's at the back of the eye is a vascular tissue. That reddish tint in the vessels that you see, those are the blood vessels that supply the neurons and glia of the back of our eye, the perfusion that keeps our eye healthy. Now, a clinician, when they diagnose diabetic eye disease, they would like to look for abnormal features within this image that might indicate that vascular perfusion is interrupted or abnormal. But clearly, the earliest stages of this vascular disease really originate in the tiniest of those vessels. Those are capillaries that provide us oxygen, metabolites, glucose, and remove the waste products of the retina in a healthy eye, and usually go awry in diabetic eye disease. So if we want to study those really tiny vessels, you might suggest that one strategy is that you just zoom in on that picture a little bit more. And I like showing this animation because it describes to us what the problem is with this strategy. Even though the eye is clear and we can see the big vessels, when you digitally zoom in on a picture, at this scale, we should be able to see the individual capillaries, but we don't because all eyes, even healthy eyes, contain something that we call aberrations. And these are slight optical imperfections of every eye and exacerbated oftentimes in diabetic eye disease that blur the image of the structures of the back of the eye. If we as researchers hope to do a better job of understanding what happened to the cells in the vascular perfusion, we'd really like to study diabetic eye disease at this level. So how are we going to address this problem? The remarkable journey that I'll tell you today starts with astronomy. And you say, why are we talking about astronomy if we're talking about diabetic eye disease? In the next few slides, hopefully I'll convince you that we have taken this journey and it is purposeful. If you were an astronomer and you were to point your telescope at a distant heavenly body, for example, distant stars or galaxies, you might get an image that looks like this. There's certainly stars and galaxies here, but they're blurred. And they're blurred because the Earth's atmosphere has aberrations, turbulence, things that blur the image. And in some of the best telescopes in the world today, they combine with the telescope something called adaptive optics. And adaptive optics is a term used for a telescope that can measure and correct for slight imperfections in the Earth's atmosphere so that we can regain really sharp images of distant objects far away. Here's another image of maybe a familiar object. This is Saturn, imaged without adaptive optics, and now with adaptive optics. So what does this have to do with diabetes? Well, the reason that adaptive optics is relevant in the human eye is that when we look at the eye and the aberrations or imperfections in the front of the eye, the same thing is happening to blur the image, which is happening in the Earth's atmosphere. The media is different, but the principles are the same. So if any of you have looked across perhaps a hot asphalt tarmac or looked through a jet wash, you might have seen the complications that give rise to a blur in an image. If you look at the image at right, which is a jet image through a jet wash, you can still see the object, but it's blurry. And this is because of thermal gradients within the atmosphere actually bend and reshape the light in a way that blurs the image. In fact, the same thing is happening in all eyes. One way that astronomers have gotten away from this problem is that they put telescopes on what are some of the highest objects on planet Earth. And in fact, this is what humans have done. They put very expensive telescopes on some of the highest peaks in the world. This is at Mauna Kea at elevation of 14,000 feet in Hawaii. And what you see from this middle image is a pair of telescopes. This is the Keck telescope, which actually, you can see in this image two beautiful things. One is clearly it's at the top of a mountain, which gets rid of a lot of the turbulence and atmospheric problems. And it's also high above the cloud, the scatter. Now, what adaptive optics has done in astronomy is it can measure and correct for that turbulence that you saw in those images that I showed before, to measure and correct for those images to get a very sharp image of a distant object. Now, the reason that this is relevant for the human eye is that in the late 1990s at the University of Rochester, there was a group that recognized some of the same problems that you could see in astronomy could also be corrected for inside the living human eye. And this is a team of David Williams and his collaborators at the time that showed some of the first images of applying this technology inside the living eye. Adaptive optics works by these principles. Here we're going to see what a clinician would normally see as they look into the back of your eye. At this projection, we're going to see a number of scale bars here at 10 millimeters, at 1 millimeter, and here just at about 1/10 of a millimeter. This is the pinch and zoom technique. But when we turn on adaptive optics, now we can regain the microscopic structure of these tiniest of capillaries inside the human eye. Not only can you see the capillaries, but you combine it with video rate mode and you can see single blood cells as well. To give you a reminder of just how tiny this is a scanning electron micrograph of a human hair to show you just how small we can go. This, of course, has high implications for diabetic eye disease because most clinicians believe that diabetic eye disease wreaks havoc on the vascular perfusion at sometimes the tiniest of capillaries, which we can see very clearly with adaptive optics. But AO has also undergone a revolution in the past few years, which allow us to see a great number of all of the retinal cell types that exist in the back of the eye. Here in the living eye, we see a cross-section in center of a cartoon of what a human eye would look like. And we see the neurons, the glia, and the blood vascular perfusion in this cross-section. With adaptive optics, we can see things like nerve fiber bundles. These are the axons that carry information to the brain. The tiniest of capillaries, about 1/10 the thickness of a human hair, photoreceptors. And then with recent innovations just in the past few years, we've been able to render contrast to highly translucent cells in the back of the eye. Because most of the eye cells are clear, this innovation has allowed us to see things like neurons, glia, and single blood cells. And then, of course, you can combine this very exciting technology with fluorescence as well. That is putting in light of one wavelength, exciting a fluorophore and imaging light at a slightly different wavelength in order to see very detailed structures of sparse structures in the back of the living eye. We're going to focus our attention today just to the innovations which are applying adaptive optics imaging into understanding the vascular perfusion. So as you saw from Dr. Sun's presentation, one of the earliest onsets of diabetic disease is believed to happen at the capillary level. And here with adaptive optics, we're not only able to see the tiniest of capillaries, but excitingly, actually image the flow and movement of single blood cells as it moves through that capillary network. The second innovation that I'll cover very briefly is we're building software tools here at the University of Rochester that allows us to combine this technology to measure the speed and velocity of hundreds of thousands of single blood cells inside the biggest vessels in the eye. And then finally, if time provides, a very exciting finding, which not only allows us to see blood cells as they're contained within the vessels of the eye, but what happens in diabetic disease when the blood cells leave those vessels. This is what we see happen in a variety of diseases, and especially diabetes, what happens in the inflammatory response of the retina. So let's turn our focus first to capillaries. These are, of course, very microscopic. And I love this image here because it shows us that at the capillary level, blood cells physically have to deform through this capillary in order to get oxygen, glucose, metabolites to the tissue and whisk away metabolic waste products. We've also undergone a bit of a revolution where we can now image not only the twinkling of those little red blood cells, but now combine this with an approach called phase contrast, which allows us to see the shape, the anatomy, and even the type of individual blood cells as it flows through this vascular network. This is highly relevant to diabetic eye disease because it's thought that the earliest events in diabetes are usually happening at the level of capillaries. And it's these stoppages and bleeds that are happening in capillaries, which may be an early diagnostic feature of the early diabetic retinopathy condition. So what we're visualizing within this image is blood. And I love showing this image because it reminds us all that the stuff that is pumping through our heart and moving through all of our organs in our body is not just a liquid, but it's comprised of, in a typical human being, over 30 trillion cells. And these cells, of course, are red blood cells, white blood cells, which are pseudocolored here in blue, and a platelet, which just so happens to be activated. These are the constituents of whole blood that is pumping through our vascular system all the time. And if we can study these things inside the living body, we're going to have greater insights to what's happening in the early dysfunction of diabetes. Our strategy is not only to boost contrast and resolution of these tissues, though, we also need to image very quickly. And for this, we've combined adaptive optics with very fast camera capture. And here what we've done is we've positioned a single scanning beam across just one vessel. And when we scan it over 30,000 scans per second, what we can do is let the blood cells scan themselves as they pass by the beam. These images are remarkable because we have a literal ticker tape record of every single blood cell that has passed by this beam, now at the single cell level. This approach has allowed us to see things that before we didn't think were possible. This is actually imaging the anatomy and deformation of single blood cells as it moves through the capillary network. Think about how this could be important for diabetes. If there's occlusions and bleeds at the level of capillaries, it'd be very important to image the single blood cells. What we found early on is that the packing density, not only the flow of the blood cells, but the packing density of those cells actually can be imaged inside the living eye and create very different flow patterns. These are all images from the healthy eye. And in a second, I'll show you what happens in conditions of disease. But cells can be densely packed, sparsely packed, interdigitate, which create this zigzag slipper form, and the very important condition that I'll illustrate at bottom, which is called interrupted. Interrupted, it has great relevance for diabetes because what we find in the eye is that the video at left shows a plug or a clog within the vascular network. And again, this is happening at the capillary level. Not only can we visualize that clog happening within the capillaries, but we can also see the removal of that clog over time. So adaptive optics gives us a tool to answer a very fundamental question. What's happening at the level of capillaries that are creating these clogs in flow? Point to the image at right, in which I'm going to illustrate a single cell that moves through this capillary network. Here we can see red blood cells moving through this capillary. And then right now we can see a single sluggish cell that moves through that capillary. That cell just so happens to be a leukocyte, a white blood cell. These are the immune cell of the circulating system. And those cells have long been implicated as an early indicator of inflammatory response in any tissue, and especially that in the retina. Here now we're able to visualize and identify that those are in fact white blood cells because we have the resolution and anatomy of those cells. Another innovation is we can turn our same adaptive optics camera not only to the tiniest of vessels, but we can also point it to the biggest of vessels. And I'm going to go over this very quickly, but we've developed software here at University of Rochester that allows us to image a fire hose of information in the biggest arterioles and venules that allow us to measure very sensitive measures of the total blood flow to the retina. This is important, of course, because here in the retinal circulation, we can image the source and return of all the blood cells coming into the retinal circulation. But the majority or the balance of today's talk, I'd like to focus on this very exciting result that deals with the inflammatory response in diabetes. So we've talked about imaging blood cells in capillaries, in very big vessels, but what happens in the inflammatory response of the retina? It's not only true in diabetes, but basically every retinal disease that has an inflammatory component, you see local swelling and inflammation of the retinal tissue. Think about what happens when you bang your thumb with a hammer. You get an increase in blood flow. You also get immune cells that start leaving that tissue in order to deal with the cleanup and debris removal in response to injury. The same thing happens at the level of the retina, but we've never been able to see what happens at the single cell level. So let's see what we can glance at using adaptive optics. Here's a reminder image that diabetes is a vascular disease of the eye, and Dr. Sun has already covered a number of the phenotypes that we see in the eye, things like arterial narrowing, nerve fiber hemorrhages, hard exudates, preretinal hemorrhages, and this, which might be slightly harder to see, is macular edema. This is, of course, the central portion of our vision, which allows us to do things like read and recognize faces. And what often happens in diabetic disease is that you get swelling of that tissue. Here's a cross section of this line. Very beautiful image by a review by Antonetti et al. Shows us that the swelling of this tissue indicates diabetic disease. Now, this technology called optical coherence tomography, which Dr. Sun introduced, allows us to measure the thickness of that tissue. But we think we can do a little bit better with adaptive optics so that we can actually visualize the single cells that are meeting that inflammation. So what I'm about to show you has been captured over the past year and a half, in which we're imaging now in an animal model of diabetes, what happens in the vascular response to inflammation. Here we're seeing a healthy retina, and this is a big vessel about the thickness of a human hair, a little bit smaller, that is fed by the optic nerve. And when we inflame that tissue, similar to what is seen in diabetic eye disease, we now see the arrival in just a few days after that inflammatory event of remarkably the emergence of single immune cells that are arriving into that tissue and beginning the process of cleanup and dealing with inflammation and debris field associated with inflammation. So we were very excited about these images, of course, because now we're able to see and study at the single cell level what happens in inflammation, an important component of diabetic eye disease. But I think that those images pale in comparison to what it is that you can capture in video rate mode. So now if we image the same tissue and do time-lapse imaging, we can see the remarkable behavior of not only those individual cells being static, but the purposeful movement of those single immune cells as they start interacting with the retinal tissue. I love these videos because every single cell can tell its own unique story, but I'm going to illustrate just two examples in this video. The first I'm going to illustrate with this red circle. If you pay attention to this location, you'll see something pretty interesting. You'll see a single cell as it comes in and out of a vessel. This cell that leaves the vessel is called, this event is called extravasation. And this is one of the earliest things that happens in the inflammatory response. To our knowledge, the first time that this has been seen inside a living eye. Let me show you another location, this one in green. And hopefully you can see at this location that there is something even more remarkable. Here we can see an immune cell that is outside of the vessel and it comes back into the vessel. This is remarkable because this really hasn't been seen in any tissue, let alone inside the living eye, and is highly controversial in the field. But again, these innovations are happening on the heels of new imaging technology that allows us to study these events inside a living eye. Of course, the imaging technology that I'm talking about is non-invasive. It's a camera that takes pictures of the back of the eye, so there's no surgery required. An ophthalmoscope is a device that never makes contact and just uses light in order to image the back of the eye. So we can also study the natural history or progression of inflammation in the eye. We're very excited to do this in the human population as well. For now, these are images that we're taking from animal research where we image the back of the eye in the healthy condition. You can see here a venule and an arterial, which is nice vascular perfusion. We inflame the eye by making a small injection of an irritant to the back of the eye, and this irritant induces inflammation. This inflammation, now we go back to the same tissue 6 hours later, and there's very interesting things that are happening. You can see my cursor. Along this venule, we can see the rolling behavior of individual immune cells. This is one of the earliest events that happens in inflammation. And here we're seeing it just 6 hours after the insult is presented to the retina. You can also see immune cells have already arrived to the tissue and begun their job of cleanup and debris mitigation.
2 minutes to wrap up, please.
Thanks, Brian. 24 hours later, same tissue, same location, but now hopefully I can convince you that the cells look very different and their behavior is remarkably different. And then of course we can see the same tissue 72 hours later, 10 days later, and then 2 months later. This temporal progression that you're seeing is something that clinicians dream of in human disease, and that is that the inflammatory response comes in, the inflammatory cells do their job, and importantly, they leave the retina intact. At 2 months later, you can see that the retina has largely returned to its native state. But unfortunately, this is something that goes awry in a variety of chronic conditions, including diabetes. And this is exciting to think that now we have a tool to study what is helpful and what is hurtful in terms of therapy in order to boost or suppress the immune cell response in diabetic eye disease. So just to summarize very quickly, adaptive optics, a tool that we borrowed from astronomy, has now helped us understand what's happening at the level of the smallest capillaries and see single cell blood cells within. We can image a fire hose of information and get the velocity from hundreds of thousands of cells in the biggest of vessels to look at the source and return of blood supply to the retina. And then finally, we've also been able to apply this in conditions of inflammation, in which diabetes is certainly an inflammatory condition. We think that the next stages and the future of this technology will help refine pharmaceutical therapies to target just the key aspects of diabetic disease in the earliest stage so that we can diagnose, treat, and monitor response to therapy in new cutting edge developments. Before I open up the floor to any questions, of course, wanted to acknowledge the group that does this work. This is a talented group here in my laboratory. Also would like to thank the Advanced Retinal Imaging Alliance, of which I'm a member here at the University of Rochester, our funding sources from the National Institutes of Health, the Dana Foundation, and a special thank you to the Research Prevent Blindness, which seeded a lot of the initial funds to make this work possible. Thank you so much.
Thank you, Jesse. So this was literally and figuratively rocket science. Fantastic work here. I'm going to get started with a couple of questions I have for either speaker here. I'm going to start with Jenny and ask Jenny, there was one question in the chat function, if you're going to answer that, and then my question. One is, what is the size of the DRCR network? Can you speak a little bit to it? And then the specific question I have for you, Jenny, is, with so many therapies coming up, and you spoke more about anti-VEGF therapies, can you just give us somewhat of an idea about, for people with diabetes, that, you know, options and choice is always great. So what are the other things along the pipeline that can benefit people, and so we can have everyone responding to a battery of therapies? So 2 questions there, and then I'll come to Jesse.
Terrific. Thanks, Sanjay. So the DRCR Retina Network, it's a fairly large collaborative network. I think the largest of its kind in the world doing research in retina disease. We have right now about 130 active clinical sites across North America, including 5 provinces in Canada. And I think we have 400 or so active retina specialist investigators with about 1,000 additional personnel. You know, one of the things that we have seen is that over the lifetime of the network, we've probably enrolled about 1/3 of the retina specialists within the US at some point or another participating in our studies. So it's got a broad reach. And one of the nice things is the ability to have a standing infrastructure to really rapidly onboard new studies, so that we've constantly got new studies in design in the pipeline that are ongoing and that are being reported out. So it gives us a good opportunity also, as you said, Sandra, to look ahead to see what is coming down the pike for people with diabetes. I'll say, you know, the anti-VEGF therapies clearly have been the mainstay of our therapy over the last 10 years, but we need to look for the next wave of therapies. And much of the interest is going to be actually moving the field into preventive strategies. So we actually have a study that's just about getting ready to up and going in terms of the oral medication fenofibrate, which is a pill that you can take that has in the past been used for cholesterol lowering, but which several studies have suggested is maybe effective also in preventing worsening of diabetic retinopathy. And I think if we can show in our next 4-year study that fenofibrate is effective in doing that, that opens up the ability to prevent worsening disease, not just in the patients that have access to very expensive, very expert retina specialists, but globally, which is incredibly important for us to be able to reach out to patients that have, you know, issues with access of care and other things to to have a medication that can be easily tolerated and that is safe. So I think that's one thing. There's a lot of interest also in looking at different ways of administering both anti-VEGF, steroid, and other medications, long-term sort of sustained release injections in the eye, or implants or devices or things that can do that. So lots of work being done. And of course, as always, another active area of interest is going to be in the artificial intelligence algorithms and their applications to identifying people with diabetic retinopathy and screening them very efficiently to get them to care if needed.
Thank you, Jenny. And we're very happy to partner with you on the phenylfibrate study. It's super exciting. Actually, my question for Jesse is, and then there's one more in the chat box. My question for Jesse is somewhat related. Jesse, this field, we have been supporting a lot of diagnostic and prognostic work, biomarkers, etc. But one of the Achilles heel in this entire line has been that has prevented people with diabetes doing better and even having preventive therapies is the cost. So the technology you discussed here, can you give us give me and the attendees a ballpark on, when can this be practically deployed in the clinics and how much of specialization is needed? What would the cost be so that we can truly leverage the translational potential of your extremely advanced technology here? So that's one thing. Then there's one more from the chat. I'll come to that, Jesse, in a second.
Great, thanks for the question, Dr. Dunn. We get asked this frequently, is when is this technology ready to be deployed in clinics all over the world? And I'll give two responses, which I think are two different takes on the same question. The first is the technology was really deployed in the eye first in the late 1990s. And so we've seen about 30 years of the technology continually innovating and getting better, but we're still not seeing a lot of these devices in clinical centers all over the world. So we're hopeful that with more commercial partners that eventually we'll take what academics know and commercialize it so it can be deployable in clinics all over the world. The second perspective, I think, is that we don't want to undermine the potential of what it is that we can see in just a few research centers globally. And what I mean by that is, if we can understand in a small cohort of diabetic patients what's happening with the greater population, we don't need to image every single diabetic eye in order for us to refine and develop treatment strategies for the population as a whole. So the instrument is quite expensive at the moment. I would put a ballpark figure of about $500,000 to build, and that might not seem like a lot depending on who you ask. It's a lot for a single person. It's not a lot for an academic center, but the real cost is the development, the alignment, and the troubleshooting needed to operate these instruments. So this is where commercialization will help. Nevertheless, we're confident that this technology will be pushing to help diabetic eye disease once we can study at the single cell level what you can do with a $500,000 machine.
Thanks, Jesse. There's one question in the chat function for you, Jesse. Can adaptive optics be combined with fluorescence imaging, like any retinal images to see?
Yes, that's a great question. So the short answer is yes. It is an imaging device where you put in one wavelength of light and you can image that same wavelength coming out, that's reflectance, or you can image what happens when you excite with one wavelength and image a slightly longer wavelength, and that's fluorescence. Now, in human eyes, there's a limited number of fluorescent agents that are approved that we can image today. The first of those is sodium fluorescein. And as Dr. Sun is familiar, sodium fluorescein can be readily imaged with adaptive optics. In fact, Richard Rosen's group has done fantastic work on this front, combining adaptive optics with fluorescence in those vessels. The other fluorescent agent has been indocyanine green, or what we call ICG, and this is an infrared dye. And there's been tremendous work at the National Eye Institute under leadership of Johnny Tam that has been able to image ICG. What's good news for diabetes is that both of these dyes, these fluorescent dyes, are vascular bound dyes. And again, can shed further light not only onto what the cellular resolution of these capillaries are, but might in the future identify aneurysm formation, aneurysm deletion, and potentially even leaks.
I don't see any more questions in the Q&A, but I do encourage you all. We have one more minute to address something, but let me just pose one thing here. Working for a patient foundation myself in the research department, though, and RPB being a very similar mission of the organization. Can both of you take 30 seconds, quick fire, and tell us, beyond funding, beyond research funding, how can organizations such as RPB and JDRF and others help? So Jenny first, what is the biggest barrier that you are trying to cross now? And then Jesse, you'll get the advantage of 30 seconds to think about the answer to that.
Okay, so I think foundations like JDRF, like RPB, can help in two major ways. One is really the ability to connect researchers. We're often siloed in our own areas, and it is really wonderful to be able to reach past, your own institution, your own specific group of collaborators, to spark collaborations that might bring much needed creativity to the field. I think the other thing that your foundations do is you remind us of the human cost of these diseases. And it is incredibly motivating to hear from you, to hear from the people in your organizations, what it means to have diabetic eye disease or to have a child with diabetic eye disease. And to me, I think that motivation from the heart is one of the biggest benefits of working with these foundations.
Thanks, Jenny. Jesse?
Yeah, I'll give two concrete examples. I think, the first one is simple, and it's funding. These foundations often support financially some of the cutting edge research that you saw today. And those funds are used to support both senior scientists at the top of their field, but also support young, burgeoning, early stage investigators. And I was, for example, the recipient of a Research Prevent Blindness Career Development Award, which really catapulted my research and a lot of the research you saw today into the exciting domain of possibility. I think the second major thing is exactly what we're doing today. These foundations can make visible and give hope to patients that suffer from these diseases so that you can understand that we're not at a loss of what we're doing today, but there's exciting things on the horizon. And I think creating that pillar of hope for patients is a very important domain of treating any disease, but also showcases the innovations that are taking place on the scientific fronts. Scientists and engineers, believe it or not, are usually very humble people. And giving a platform where the public can appreciate some of these innovations is a very powerful thing that these foundations are doing.
Thank you, Jesse. With that, I want to turn it back to our chair, Brian Hufflin, to close this out here.
Thank you, Dr. Duda. I'd like to thank our two presenters, Dr. Sun and Dr. Shalik, for really exciting presentations. It was wonderful to hear not only the remarkable clinical advances that have been made, but also to learn about some of the exciting science developments that are allowing us to see at the very small molecular level what is going on with diabetic retinopathy in the eye itself. And also, Dr. Duda, I want to thank you for a fine job of moderating. Thank you very much. And thank you for all of you who joined in today. We've completed 3 Lunch and Learn events now, and the prior 2 events covered glaucoma and AMD. And we invite you to visit the RPB website at www.rpbusa.org if you would like to see recordings of those events. And we'll also be reaching out to everyone that participated in today's event with a recording of today's session. If you have ideas for further topics that you would like us to cover in future RPB educational events, please reach out to our team at info@rpbusa.org or to any of our staff persons directly. And with that, I will just say thank you again to all. And this is the conclusion of our session today. Thank you.